Okay, Shiv, we are going to start now.
Okay.
Okay. Shiv, so we are really thankful to the Acula division of the INTAS. They have wonderfully arranged this panel for us.
Yep.
And we are highly thankful to Mr. Group Singh, who is the Vice President of Acula division of INTAS, Mr. Ajay Kota, who is the Marketing Head of the Acula division of INTAS, and the ground staff that is working with them. Mr. Prashant, who is taking care of the whole this webinar, and all other people who are the ground staff of Acula division. We are really thankful to them. So, just being brief enough, I'm just giving a small introduction of Dr. Shiv. Dr. Shiv is a very eminent personality in anesthesia, and Dr. Shiv is a consultant of anesthesia in the Royal Liverpool University Hospital in UK. He did his MBBS from the Jipmer Madras University. Dr. Shiv has done his MD in anesthesiology from the AIIMS New Delhi. Dr. Shiv is an FRCS from the Royal College of Anesthesiologists in London. He is a visiting faculty to BIDMT, Harvard Medical School Hospital. Dr. Shiv is the faculty and the organizer of the ultrasound guided regional anesthesia workshop for the trainees and for the consultants. Dr. Shiv is a faculty workshop in the management of difficult airway. Dr. Shiv is the faculty of the Liverpool course for the...
Rohit, leave it, man. There is no need for all that.
Dr. Shiv is so much. So I don't want to go into the depths of Dr. Shiv. So Dr. Shiv, before starting your lecture, I would just request Dr. Gurmeet to speak. Dr. Gurmeet sir is the president of IAS Jammu, and he is my teacher also, my guru also. So I would request him to say a few words before we start the webinar and hand over the mic to Dr. Shiv. Gurmeet sir.
He's on mute.
Gurmeet sir, can you hear us?
Sir, your mic is mute. Can you unmute your mic, please?
Gurmeet sir? So,
hello.
Gurmeet sir?
Hello.
Gurmeet sir, can you please speak? Can you please speak some words for before starting with the webinar?
It's still on mute.
Gurmeet sir?
Yes. Can you hear me?
Yes.
Yes, we can hear you now, sir.
Good evening, Dr. Shiv Kumar Singh, Dr. Rohit Lahori, and eminent faculty who have joined us this evening on a webinar on applying current practices, trends in perioperative analgesia, options and alternatives. Dr. Lahori has already introduced our eminent speaker, Dr. Shiv Kumar Singh, so I won't be adding anything on it. Personally, I have heard and read about you, sir, but it is going to be the first direct interaction with you. We all hope that it will be an academic feast and a wonderful experience listening to you on a very important, less understood and underutilized field of perioperative anesthesia.
I hope so.
I welcome Dr. Shiv Kumar Singh on behalf of Indian Association of Anesthesiologists, Jammu chapter. Sir, please.
Oh, thank you, Dr. Gurmeet. And thank you, Rohit, for...
Dr. Shiv, the mic goes with you, and please carry on.
Thank you. Thank you very much. And thank you for inviting me to deliver this lecture. So I'm going to start the lecture without any further ado, because this is a long lecture and a lot of people are actually waiting to hear this. Okay. So here we go.
In perioperative analgesia, the options and alternatives today. My name is Dr. Shiv Kumar Singh. I'm a consultant in anesthesia. I'm working at the University Hospital, Liverpool. I have nothing to declare. The images that I have used are courtesy Google, and some of them are my own. I have no affiliation to any pharmaceutical companies. Optimal pain management need to be individualized, and it need to be multimodal. That is, it should include all the 5 components of pain. That is a sensory component, cognitive component, psychological, social cultural, and affective components. When we talk about acute pain management, we are actually thinking of one, that is the early recovery after surgery, and the second is prevention of complications. When we talk about ERAs, we are looking at discharging the patient early Whereas looking at prevention of complication, we are talking about the persistent post-surgical pain and chronic pain, prevention of these two components. There are a few terms which are used when we talk about pain, and preventive analgesia is one of them. Preventive analgesia basically is combination of preemptive analgesia, that is analgesia which is delivered before the surgical incision, and multimodal analgesia that is used during the surgery and in the post-operative period. The World Health Organization has emphasized on using 5 phrases for correct use of analgesics. The first of which is by mouth. That is delivering the pain medication orally. Second is delivering this medication by the clock rather than on demand for at least for the first 48 to 72 hours. Then assessing and treating the pain appropriately using the WHO ladder. It does not mean that we have to go one step by the next. We can be on step 3 straight away. The patient might wake up with severe pain. That means we use a strong analgesic. We can also actually bypass the steps. So we might be on step 1, but the simple analgesics didn't work and the pain became very severe. Then we can move on straight on to the step 3. And the analgesics need to be individualized. Everyone reacts and responds to pain in a different way. And hence the treatment should depend on that too. We need to pay attention to details. We need to be very sure how we prescribe the medications, okay, and what we prescribe in it, when they need to be administered, what time, for how long. And we also need to monitor its effects. Are they really working? Okay. And are they causing any side effects? We need to use adjuvants to improve analgesia and to minimize the side effects. We know that the opiates are associated with nausea and vomiting and with constipation. So we should actually prescribe patients antiemetics and maybe laxatives as well. Anti-inflammatories are an important part of analgesia management, and they need to be prescribed into the post-operative period as well. Some patients might need psychotropic drugs to alleviate their anxiety, improve their sleep and mood, and it is also an important part of analgesia management. So having introduced the management of acute pain broadly, we will now go into physiology of pain, where we'll discuss about the receptors involved, the primary afferent conduction, how it happens, how the integration of pain occurs in the dorsal horn, the ascending and descending pathways involved in pain, and the chemicals involved. So the pain, the tissue injury, all will induce the nociceptors. They will get activated. They get activated by heat, chemical, pressure. Then through the primary afferent, they reach the dorsal horn. These nociceptors are present in the skin, in the muscles, in the connective tissue, in blood vessels, in the viscera. So wherever we're going to have surgery, these will be activated. And then they are transmitted to the dorsal horn. And there is also antidromic stimulation, which causes release of certain substances like substance P, calcitonin, gene-related peptides, that is CGRP, and neurokinase, or neurokinin K. These substances then act on the tachykinin receptors, which are present on the blood vessels and tissues. And this causes vasodilation and edema. And we would have observed that wherever there is tissue injury, the area around it is swollen, as well as it's very sensitive. That increased sensitivity happens because these substances again, increased sensitization of the nociceptors. The primary afferent conduction occurs through A delta and C fibers and A beta fibers. The A delta and C fibers are the main fibers, or the primary afferent fibers, which conduct at a very high velocity at 0.5 to 15 meters per second. The C fibers are slow adaptive, whereas the A delta fiber are fast adaptive fibers. And the C fibers, they conduct the slow, aching, diffuse, and dull pain. I call it sad pain. It's sad. It's slow. It's aching. It is diffuse. Whereas the A delta fibers tend to conduct the rapid pricking and well-localized pain. The integration of all this occur at the dorsal horn. So the nociceptive afferent fibers, the interneurons, and descending fibers converge at the dorsal horn. When a nociceptive signal comes in, there is increased conductance of calcium. You can actually see that on the right side of the fibers. This increased calcium conductance leads to release of glutamate and neuropeptides. On the projection neurons, you can actually see on the lower part, there is increased potassium conductance. This leads to depolarization of these neurons. The interneurons are usually inhibitory. They release enkephalin in normal situations. This is also the site where the opioids will actually act. The neurotransmitters in the descending pathways are norepinephrine and serotonin, and enkephalin as well. I mean, that is through the interneurons, but also through the descending fibers, and we will actually discuss that in a little while. So the dorsal horn is actually, in a laminates, the various laminae 1 to 6. These are called Rex laminae. And we have seen that A beta fibers, which also, interact. There is actually a collateral going to the your C fibers in the lamina 2. That is a substantial gelatinous. This is where the so-called gate. So you know about the gate control theory, where when you rub. So when you're rubbing it, that is the mechanoreceptors are activated through the A beta fibers. Then this actually goes and inhibit the transmission through the C fibers. And this is how the gate control theory actually works. So the pain is then transmitted through the contralateral side, so the ventrolateral part of the spinal cord that transmits the pain through the spinal-reticular system. And from there, it is transmitted from medulla to the brainstem reticular formation. That's why it's called the spinal reticular tract. And from there to the hypothalamus, and then to the diffuse projection into this cortex. The other pathway is through the spinothalamic tract, and this sends a collateral to the periaqueductal gray, the PAG. This is a very, very important part in pain management. And then from there, it goes to the thalamus, and that's why it is spinothalamic tract. And then from there to the postcentral gyrus. So that is the ascending pathway of pain. Now, if you look at the descending pathway, one important thing is that it is tonically active all the time. So, descending pathway, which converge on the dorsal horn, is always active. And so the fibers from the cortex, from thalamus and hypothalamus, they pass to the midbrain. That's where the preaqueductal gray matter is present. And this is where your opioids actually act. We also saw from the ascending pathway that there was a collateral from the spinothalamic tract. So the integration of those ascending pathway, transmission of the nociceptive responses also occur at the periaqueductal gray. From the PAG, the this transmission occurs to the medulla at two places. One is the nucleus raphe-magnus, or NRM, and the locus ceruleus, or LC. Now, both of these have different transmitters at the dorsal horn, because these project to the dorsal horn as the descending pathways. So the fibers from the NRM, they use enkephalin and 5-hydroxytryptamine, that is serotonin, as the neurotransmitters, whereas the fibers from the locus ceruleus actually use norepinephrine. Okay. So there are different neurotransmitters involved in modulation of pain at the dorsal horn. So if we look at the descending brainstem neurons, they have direct action to prevent pain. They can cause inhibition of excitatory neurons, or they might excite the inhibitory interneurons, which are again inhibitory on the primary afferents. So there are three different ways in which the descending brainstem neurons can modulate pain at the dorsal horn level. So what we were talking about till now is the somatic pain, but the visceral pain is different. One thing about visceral pain is that there is relative deficiency of A delta nerve fibers. Okay, so the pain is not that well localized in cases of the visceral pain. It's poorly localized. And it is also associated with nausea and vomiting and autonomic disturbances. The pain is usually spasmodic, and it is often referred to the somatic structures. And the pain is elicited by distension of the viscera, ischemia, and inflammation. So these three things are important. So you can actually cut the, the gut without causing any pain. So sharp pain is not actually, transmitted through the viscera. It is because there is no A delta fibers there, or there is paucity of the A delta fibers. So what are the neurotransmitters which are involved? I talked about some of them. So when we actually have a tissue injury, there is increased release of potassium. And this is very important because this potassium directly depolarizes the nerve terminal and makes a nociceptive more responsive. So there is increased sensitization. There is release of bradykinin, 5-hydroxytryptamine, that is serotonin, and also prostaglandins, which I will again talk to in a minute. Now there is also antidromic transmission, which releases substance P, and CGRP, that is the calcitonin gene-related peptide, which acts on the mast cells and cause decarylation and release of histamine. The CGRP and substance P also acts on the blood vessels, on the tachykinin receptors, and cause vasodilation and the edema which ensues from this vasodilation in the tissues. When there is a surgical insult, there is rupture of the cell membrane. This releases arachidonic acid, and we know that this is important for release of the prostaglandins. These prostaglandins G2 and H2 also cause nociceptor activation and peripheral sensitization. And this is an area where our non-steroidals actually work. So that was about the physiology of pain. And now what about the pharmacology of pain management? So the main components of pain management are opiate and non-opiate drugs. So we'll talk about these because these are very important for us. And the foremost nociceptive drugs or anti-nociceptive drugs are opioids. Now, opioid receptors are present in the spinal cord. They are present in the periaqueductal gray, the PAG, in the midbrain. They're present centrally in the amygdala, in the medulla, in the cortex. So when we use opioids, they cause disruption of information transmission in the nociceptive circuit. Okay. So if you look at the right side, as I explained, when the nociceptive stimulus comes in, there is conductance of calcium. Calcium moves in to the cells. Okay. And this causes release of the neuropeptides and glutamate. And this happens to the voltage-gated calcium channels. So the opiates reduce or decrease conductance by acting on this voltage-gated calcium channels. And therefore, there is decreased transmission. At the same time, at the projection neurons, that is in the lower part, you can see it, they cause increased inward movement of potassium, and this causes hyperpolarization. So there is decreased conduction of impulses as well. Okay. So there is reduced amount of the neurotransmitters being released, as well as hyperpolarization, which even if there is some amount of release, this signals won't be transmitted through the projection neurons because there is hyperpolarization. So from this diagram, we can actually see that the opioids act at the cortical level, in the thalamus and in the amygdala, in the cortex. It acts on the midbrain at the periaqueductal grade, that is PAG. They act in the medulla and the rostroventral medulla, the RVM, and at the spinal cord in the dorsal column at the interneuron level. So opiates receptors are present in the various parts of the central nervous system. This is a simplified diagram explaining how the opiate works centrally, right? So they decrease the nociceptive information processing. So by acting on the cortex or at the amygdala level, okay, the perception is changed. There is a feel-good component with opiates. Patients feel nice. There is euphoric effect of opiate seen. At the spinal level, they block the afferent dissociative inputs, and they also actually enhance descending inhibition. So through the pyridoxytryptamine, through the enkephalin, and the release of norepinephrine at the dorsal horn, they enhance the descending inhibition so that the nociceptive stimulus are not transmitted further through the ascending pathway. They also have a cholinergic effect as well. So you can actually see opiate acts through acetylcholine as well at the thalamus level, okay, at the central level. So the inhibitory actions on the brainstem leads to decrease in arousal. So this is where the sedation effect occurs from morphine. So morphine does cause sedation, isn't it? At the same time, we know that sympathetic stimulation causes tachycardia, release of, the catecholamines. So this effect through the cholinergic input on the SN node causes bradycardia and thus mitigates the sympathetic response to nociception. So it acts there as well. Now, opiates can be taken orally. We can give them intravenously. We can use spinal opiates. We can use them epidurally. So we're now looking into, what is the evidence base. So the first one is looking at patient-controlled analgesia, where the patient can deliver opiates to themselves, or nurse-controlled analgesia that happens in the the intensive care units or the cardiac intensive care. So they looked at 10 randomized controlled trials between the PCA and NCA, and they found that there is reduced VAS scores at 48 hours, but not at 24 hours. And not surprisingly, there is increased cumulative morphine consumption at 24 hours because patients are happily, pressing the button to get their morphine in anticipation sometimes. But there is no difference between the patient-controlled analgesia or nurse-controlled analgesia in terms of the ICU length of stay in the hospital, patient satisfaction, sedation score, incidence of nausea and vomiting, respiratory depression, and other effects. There is no much difference. In the Cochrane review on patient-controlled analgesia, they looked at around 55 studies with large numbers, 2023 receiving PCA and 1,838 patients receiving the nurse-controlled analgesia. Again, PCA provided better pain control and greater patient satisfaction. There was obviously increased consumption of opiates, but there was increased incidence of pruritus. But there was no difference in length of hospital stay, whether it was patient control or nurse control analgesia. So what about the epidural opioid? I mean, we use that very commonly. It's used in abdominal surgeries. It is used in obstetrics. So they were looking at the abdominal aortic surgeries. And they looked at 15 trials, large numbers, 297 patients, 633 received epidural, and 664 received systemic opioid, so the IV or PCA opioid. The epidural group obviously showed significant lower VAS scores for pain on movement. And this was obviously seen up to 3 days. That is, the catheter obviously was kept for 3 days. So it provides better pain relief. And also, if there were epidural was used, then there was early tracheal extubation. And as far as the prolonged postoperative mechanical ventilation, myocardial infarction, gastric complication, or renal complication, these are all reduced by epidural analgesia. Again, in a Cochrane review looking at epidural local anesthetic versus opioid-based regimens. Again, this is seen in abdominal surgery study. There were a small number of patients, but what they concluded was that, yes, there was reduced time of GI functions, that is GI function earlier. There was slight reduction in VAS scores, but there is no significant difference in the post-op nausea, vomiting, or other complication of abdominal surgeries. So they seem to actually say that there is not much difference between the epidural and the PCA. So next one, again, a Cochrane database review about continuous epidural analgesia. Looked at 9 randomized controlled trial compared with IV PCA. And they suggested that the continuous epidural analgesia had better pain control in the first 72 hours. But there was no difference in the length of stay or adverse event between the two routes. And epidural opioids were actually causing more pruritus in the patients. There was reduced post-operative pain and ileus, but there was increased incidence of pruritus, hypertension, and neuroretention in the epidural anesthesia group in colorectal surgeries. And this may be the reason why epidural analgesia is not part of the ERAS for colorectal surgery. They do use spinal opioids, single dose, but they don't actually use continuous epidural analgesia in colorectal surgery when it is part of the ERAS. So what about use of intrathecal morphine? So the patients actually get intrathecal morphine intraoperatively, and the postoperative get a PCA morphine. So these are two groups. So both groups are getting PCA, but one group was also receiving intrathecal morphine. So what was the difference? And this was for major abdominal surgery in 60 patients, and they saw that analgesia at rest and while coughing was better in patients who had intrathecal morphine and PCA on the first postoperative day. And there's no surprise to this because intrathecal morphine provides analgesia, very good analgesia, for the duration of the time it acts. That is the first, anywhere from 18 to 24 hours. And again, not surprising, morphine consumption was lower in the intrathecal morphine group in the first postoperative day, but it was going to be no different in the second postoperative day. Nausea and vomiting were more frequent with intrathecal morphine because you have delivered morphine directly into the spinal cord. And they were using PCA morphine as well. So the incidence was much higher in the first postoperative day for the nausea and vomiting. There were no incidents of respiratory depression, and satisfaction was high in both groups. This is seen in any PCA group. It's not surprising at all. When patients are given the control for their own pain relief, the satisfaction always seems to be higher. So that was about opiates, whether they were systemic opiates or intrathecal opiates or epidural opiates. So that is the evidence base in that. Next, we come to the most commonly used non-opiate analgesic, that is paracetamol or acetaminophen. So how does the paracetamol work? So the analgesic effect is considered to be because of the indirect activation of the cannabinoid receptor, that is CB1. Acetaminophen, that is paracetamol, which we take orally, is metabolized in the liver to para-aminophenol, and it's in conjugated form. It forms the N-arachidonyl phenolamine, which is an endogenous cannabinoid. This NAPA is agonist at the transient receptor protein, the vanillite 1 protein, TPRV1, and inhibition of cellular anandamide uptake occurs by this, and this leads to increased levels of endogenous cannabinoids. So basically, the analgesic effect is indirect activation of cannabinoid receptors at the brain level. The paracetamol also seems to inhibit prostaglandin synthesis of the prostaglandin H2. But this occurs in the brain where there is high concentration of fatty acid amide hydrolase, the FAH. This doesn't have any anti-inflammatory effect, so this is not happening at the tissue level. So the acetaminophen, even though it inhibits the prostaglandin synthesis, but this is happening at central level. This is not happening at the peripheral level. So the analgesic effect of paracetamol is a direct analgesic effect, and also by the modulation effect. Okay. So there is anandamide reuptake inhibition, which increases the central cannabinoid or endogenous cannabinoid CB1 increase. So what is the evidence behind acetaminophen? Does it really work? So this is from the Cochrane review. 51 studies, large number of patients, 5,762 patients, of which 3,277 in the active group and 2,425 in the placebo group. So there's 50% reduction in pain, and the number needed to treat with 1 gram or 5 gram is around 3.5 to 3.6. And compared to the placebo, only 50% of the paracetamol group required additional analgesia, whereas it was 70% in the placebo group. What is more important is that 21 studies looked at the paracetamol alone or in combination, and obviously found that there is increased efficacy of the combination. That is when paracetamol is used along with other agents. Paracetamol is used intravenously, and what is important to see is that this was actually, now we looked at studies in orthopedic surgery, laminectomies, abdominal, gynecology, cardiac, and thoracic. And what was seen is that IV paracetamol improved patient satisfaction. and it lowers morphine consumption by almost 61%, which is significant. It also decreases the incidence of vomiting. And it's important to actually notice, to see this, that there is no statistical difference in the rates of adverse event, including the liver function abnormalities compared to placebos. So IV paracetamol, if you use in the right dose at the right time, that is 1 gram IV every 6 hourly, so you do not exceed more than 4 grams in 24 hours, is pretty safe. Now, this is a very recent paper, actually, rather this was actually released just this month, and they are talking about fixed dose combination. Paracetamol is available, in a fixed dose combination along with tramadol, codeine, and oxycodone. And I would like to discuss this in a little bit more details because this has great implications in the management of post-operative pain. Tramadol with paracetamol has been available for a very long time as Tremacet. Next, we come to two important drugs, ketamine and magnesium sulfate. Both of these are NMDA receptor blockers, work in a slightly different way. And we know that glutamate is a primary excitatory neurotransmitter in the nervous system. So when the depolarization of C fibers occur, it releases glutamate. That is, there is increased conduction of calcium, which causes the release of glutamate, which acts on the NMDA receptor or an AMP receptor. And when there is depolarization, and if this depolarization continues, then there is activation of the NMDA receptors. And this can lead to increased calcium conductance into the dorsal horn, which is shown on the right side, and this can lead to central sensitization, hyperalgesia, allodynia. So that's very, very important that the NMDA receptors are not activated. So we, use the drugs like ketamine and magnesium to block the NMDA receptors. So ketamine obviously blocks the PCP receptors, the phencyclidine receptors, whereas magnesium physically actually blocks the channels, the NMDA channels. And thus there is no transmission, they reduce the transmission of the nociceptive inputs. So ketamine, that's how ketamine acts peripherally at the the dorsal horn level. It will cause the blocking of the nociceptive receptors into the spinal cord. Ketamine acts centrally, and there are NMDA receptors present in the cortex and also at the spinal level. So the right side diagram actually shows that. So these are GABAergic receptors. The interneurons are stimulated by ketamine and magnesium centrally as well as peripherally. So ketamine and magnesium work in a similar way. So at low doses, also there is stimulation of these receptors. But with low doses, there is less amount of sedation as compared to the high doses. High doses can actually cause profound unconsciousness because we know that all our agents like benzodiazepines and barbiturates, they work at the GABAergic receptors. So does ketamine. So they can cause sedation, and we know that it can be used as induction in there. So what is the evidence base for ketamine, intravenous ketamine? So systematic review of 70 studies, 4,700 patients, 2,652 in ketamine group, 2,049 placebo group. And they've seen that there is a reduction in total opioid consumption. And there is increase in time for the first analgesic requirement by the patients, and this is statistically significant. And it has been seen to be efficacious in thoracic, upper abdominal, major orthopedic surgeries. And obviously, I mean, the 78% of the patients tend to have experienced less pain than the placebo group in patients who receive ketamine. There's obviously a problem with things like hallucination and nightmares, which are associated with ketamine, and these can occur without increase in the sedation level. One of the other advantages of using ketamine as the adjuvant in pain management is that it causes less amount of nausea and vomiting in patients. The other important thing is that the analgesic effect of ketamine is independent of the type of intraoperative opiate use. It does not matter what opiate you use, whether you use fentanyl or you use ketamine, you use remifentanil, does not matter. Other thing is the time of ketamine administration and the dose used are totally independent of the analgesic effect. So you can actually give ketamine before incision, you can use intraoperatively, and the dose used as well. You can actually use low dose ketamine infusion throughout. So even using like 25 to 50 milligrams of ketamine before the incision actually have a marked effect on the requirement for analgesic in the post-operative period. And like I said, magnesium is another agent which is available to all of us. It also acts through the NMDA receptors, and it's a very good adjuvant for reducing the dose for antinociceptive agents. So it reduces the requirement for opiates and other analgesics. And it can act centrally as well. And in high doses, you need to be very careful. Don't use doses like used in the eclampsia patients because it can cause decrease in AV conduction, and it can lead to heart blocks and in some patients cardiac arrest. It does potentiate sedation, so using it too late into the surgery with the residual effect, you can actually have slow awakening in the post-operative period. The other group of agents which are very important are the alpha-2 adrenergic receptors. These are dexmedetomidine and clonidine. In India, dexmedetomidine is easily available, whereas for us, it is actually a very costly drug. So we tend to actually use clonidine, which is a cheaper drug. So clonidine and dexmedetomidine obviously act centrally as well as peripherally. Peripherally, they act at the spinal cord level in the dorsal horn, and centrally, they act in the cortex and in the midbrain as well. So they activate the inhibitory interneurons and thus enhance the descending inhibition of nociceptive transmission. They can also act presynaptically to decrease the release of norepinephrine centrally, and this is what causes the sedation effect of dexmedetomidine and clonidine. So both of them are associated with sedation. So what does the evidence actually tell us? What about the meta-analysis and randomized controlled trials? What has been seen that alpha-2 agonists, they provide moderate amount of analgesia. They may be better than paracetamol, but not better than ketamine or non-steroidals. So they are very good as part of the multimodal analgesia, but on their own, they may not be better than ketamine and non-steroidal. The other problem associated with use of dexmedetomidine as a single agent is they can cause severe hypertension and bradycardia. And hence, dexmedetomidine has often been used along with ketamine and other agents. Dexcat is a very popular combination used by many. So the meta-analysis and RCD also actually talk about the extra analgesic benefits of using these alpha-2 agonists, that they are very good sedatives. So they're good for using in day case procedures where sedation is required. They cause anxiolysis, they provide analgesia, they reduce post-op shivering, reduce post-op nausea and vomiting agitation. They also mitigate the stress response to surgery and tracheal intubation, and obviously have anesthetic sparing effects. So if you're using it during intraoperative period, you can reduce the amount of the propofol or the volatile anesthetic use. They can also be used along with the local anesthetic as part of the neuraxial and peripheral nerve blocks. And in very high-risk vascular patients, they have been shown to decrease perioperative mortality and myocardial infarction. I think this may be related to their effect on the heart rate, because the bradycardia it causes. So slow heart rates are very good in these patients. Next are the non-steroids and lignocaine. These two agents are available to everyone, very easy to use, and provide very good analgesia. So when surgical insult occur, there is destruction of the cell membrane, there is release of arachidonic acid, and this leads to production of prostaglandin G2 and H2. And this is where the non-steroidal acts. At the same time, the surgical insert causes cellular inflammatory response. There is activation of mast cells which release histamine. And these histamines actually cause activation of the polynuclear cells. And this is where the lignocaine actually works. The lignocaine blocks the neutrophil priming. Activated neutrophils are involved in amplifying the inflammatory response. So local anesthetic acts as anti-inflammatory agents. So they cause down regulation of the neutrophil degranulation. So fantastic agents to use, easy to use as well. And this I have already explained to you in the earlier diagram, how the agents released the various amount of the neurotransmitters released when there is tissue injury. So we know that non-steroidals can be specific and non-specific. Non-specific, for example, the diclofenac, ibuprofen, where the specific the COX inhibitors, and they have anti-nociceptive and anti-inflammatory effect because they prevent the formation of prostaglandins, which are involved in the peripheral sensitization. So looking at the evidence base, they've seen that single-dose oral ibuprofen, this was looked at in the 72 randomized controlled trial, huge number of patients, 9,168 patients. There is more than 50% pain relief in patients with moderate to severe postoperative pain. And there were no increased adverse events. They were similar to placebos. So non-selective, non-steroids like ibuprofen are commonly, we use them in most of our cases in the postoperative. Coming to celecoxib, which is a selective inhibitor. And this looked at 10 studies, 1,785 patients. And so dose of 400 milligrams is actually better. And the time to rescue medication is markedly increased compared to the placebo. And the requirement for rescue medication is also markedly reduced to 63% as compared to 91% in placebo group. And the adverse events were mild to moderate in all groups. There was no difference in the frequency between the placebo group or the selective NSAID groups. Obviously, recently there have been issues about that, the use of these non-steroids can cause heart disease, and they use. But that is again for long term, where patients, and we're not talking here about long term use in post-operative period. We're talking about use for maybe initially 72 hours, and later on using them as and when required. Injectable non-steroidal ketorolac has fallen out of use. We don't use as much, but there are studies looking at its analgesic efficacy, and they tend to reduce opiate consumption by almost 30%, and they facilitate quicker recovery and rehabilitation. Some places are still using lower doses of ketorolac. For higher doses in elderly patients and patients who are dehydrated, you need to be very careful. Ibuprofen, injectable ibuprofen is available in US, and it has seen that a dose of 800 milligram reduces morphine consumption by 22% in the first 24 hours. And there is significant reduction in pain at rest and with movement. As far as adverse drug reaction are concerned, there is no significant increase as compared to placebo. So another drug for orthopedic and abdominal surgeries and other surgeries. Lignocaine, one of our new favorites. We all use it for regional anesthesia. We know that it blocks this sodium channel. Same thing actually helps as well in the management of pain. So when we actually use lignocaine as infusion, I've already explained that basically we know that tissue injury leads to priming of the neutrophils, which are degranulated, and this degranulation causes amplification and inflammatory response. And it has been seen that lignocaine, when used at very low concentrations, are able to block this neutrophil priming, and hence there is downregulation of neutrophil degranulation and hence reduction of the inflammatory response. So lignocaine is actually helping in reducing the nociceptive responses as well as causing the anti-inflammatory response. It has also been now recently realized that sodium channels, lignocaine not only blocks the sodium channels, but it also acts on NMDA receptors. So this acts at the glycine receptors in the brainstem and amygdala, so the cortex, and diminishes nociceptive transmission and can also lead to a bit of sedation. Okay. So the central effects of lignocaine have been realized as well. So what does evidence say? Meta-analysis after abdominal surgeries, they looked at 8 trials. 161 patients received lignocaine, 159 received just saline. Okay. And both patients were allowed to use opiates as and when required. What they found in the lignocaine IV group that there is decreased duration of ileus, there is reduction in the length of stay in the hospital, the reduction in the post-operative pain intensity, reduction in the incidence of post-op nausea and vomiting, and 30 to 50% reduction in opioid consumption. Now that's a significant reduction, 30 to 50%, just with use of lignocaine. That's really good. In another systematic review, looking at various surgeries like abdominal tonsillectomy, total hip, and coronary artery bypass. Now, I want you to actually look at this very closely because this has got greater implication. So 16 trials, 395 patients received lignocaine, 369 received saline. And again, all could receive opiates as required. So in patients who received IV lidocaine, pain score were reduced at rest and with cough or movement up to 48 hours post-operatively in abdominal surgery patients. So this is excellent because abdominal surgery, coughing and movement, these are important to prevent respiratory complications which are associated with, especially with upper abdominal surgery. But there was no impact on post-operative analgesia in patient undergoing tonsillectomy, total hips, or coronary artery bypass. So in these surgeries, actually, there is probably not much effect of the IV lidocaine. It did reduce the duration of ileus, length of hospital stay. Post-operative pain intensity was reduced. There was less incidence of post-op nausea and vomiting. And there was absolutely 85 reduction in opioid consumption in the abdominal surgery cases. Now that is again very, very significant. Okay. So use it, guys. Use it. This is something which is very useful for people who do not have access to opioids. Okay. Now, lignocaine and other local anesthetic can also be used for wound infiltration. Again, these are important, and they were actually seem to be useful in cardiothoracic, abdominal, gynecological, colorectal, head and neck, and orthopedic surgeries. So there is no increased incidence of infection or toxicity in any of these clinical situations. And this is again very, very important, that using it preoperatively, so blocking preoperatively is superior to using it postoperatively. So if you want to infiltrate the wound, infiltrate it before the incision. The infiltration after the end or at the end of surgery actually is not that effective. And pain is reduced both at rest and at mobilization, which is actually fantastic. And like I already explained, there is almost 85% reduction in opioid requirement when you use IV lignocaine. And with wound infiltration, again, there is a significant reduction in opioid. And in breast surgery, breast cancer surgeries, it was seen. One study sees that they decrease occurrence of acute and chronic pain at 3 and 6 months after the surgery. Now you need to be careful when you're using IV lignocaine as infusion, and then you want to use other local anesthetic for wound infiltration. You need to be careful with the drug toxicity. So you do not want to exceed the total safe limits for the local anesthetic. And here local anesthetic is not individual, it's combined. It is not an individual drug dose. The other group of agents which are used as part of the preemptive analgesia are GABA analogs. So we know that benzodiazepine and barbiturates act on GABA A receptors. They increase the chloride conductance, and that's how they work. But there are two agents, gabapentin and pregabalin, which act through the GABA B receptors. They act on to the voltage-directed calcium channels. They inhibit conductance of calcium. And these have been used for a while. Now, gabapentinoids in April last year in UK have been classified as Class C controlled substance. So they are similar to your opioid prescription. So this is to reduce the abuse of gabapentin and pregabalin. So what does the systematic reviews tell about that? So gabapentin was seen in 22 trials, 1,640 patients. Pregabalin 8 trials in 707 patients. So gabapentin does provide better post-operative analgesia. It helps in sparing rescue analgesics as compared to placebo. And these are administered, like I said, these are part of preemptive analgesia. We tend to administer this in the preoperative period. Rather, some of them start this pregabalin or gabapentin 1 or 2 days before the day of surgery. Now, 14 of the 20 trials, 14 randomized controls trials says that gabapentin did not reduce post-op nausea and vomiting, as has been previously advocated. Looking at pregabalin, it says it also provides better post-operative analgesia as compared to placebo. But 4 studies reported no pregabalin effect on preventing post-op nausea and vomiting. So gabapentin and pregabalin, they do not actually have much effect on prevention of post-op nausea and vomiting. And the reduction in opioid consumption is about 30%. So not as good as lignocaine, IV lignocaine, but it does actually, they do help. So they should be part of the multimodal analgesia. No harm in using that. So that was the basics of the pain management. So we're talking about the physiology, pharmacology. Next, we will look at the practical approach with some examples. And so the first is a case of Lahori in a 38-year-old woman. And she wants to discuss post-operative analgesia because her experience has not been good in the past when she had ambulatory laparoscopic gynecological procedure. So one thing we need to remember, pain management is more than just use of these pharmacological agents or nerve blocks. We need to align the expectations of the patient. We need to be realistic about the pain. You cannot actually tell the patient that there'll be no pain at all, because if you tell them, and then patient actually has pain in the post-operative period, it is going to cause disappointment, and that can also lead to fear and anxiety that something might have gone wrong. That's why patient is feeling pain. So it's important to align the expectations. We need to plan and educate the patient. You need to educate the patient about the degree of pain expected. We need to discuss how we are going to assess pain in the post-operative period and how we're going to manage this pain based on this assessment. We need to reduce the anxiety, patient anxiety, by explaining what their expectation is going to be, what can happen, why things can go wrong, or why the patients, despite giving appropriate analgesia, why patient might still feel pain. So it's important to communicate the analgesic rate. It is important to tell them that breathing exercises, coughing, ambulation, and post-operative rehabilitation are an important part of the whole package. There are going to be, incisions or port sites just below the ribs. Taking deep breaths can initiate pain. Coughing can initiate pain. And if possible, patients should be provided information in form of leaflets. They need to be told that they can be, this is obviously communicated mostly by the surgeons, that there may be a small chance that the laparoscopic surgery might convert into an open surgery. And when this happens, there are going to be pain associated with the incision. There can be visual pain. And then they can be referred pain to the shoulder. Okay. So patient might think, I didn't actually have any surgery on the shoulder. Why am I having this pain? They need to be told that the use of analgesia and as a part of the surgery, these patients can have sickness. When patient is actually having nausea, vomiting, retching, that itself can cause pain. Okay. And they need to be told that we will actually give prophylaxis and that they would be actually written up for antiemetics in the post-operative period, and that we will actually risk assess them and treat them accordingly. So again, the risk assessment starts from the pre-operative period. Depending on the risk score, you will actually use prophylaxis and you will prescribe appropriate antiemetics. When the patients are discharged to the ward, you need to make sure that they are prescribed appropriate medications for managing pain and managing nausea and vomiting as well. And if there are going to be day cases, they need to again be told what medications they need to take and what time they need to take, for how long they need to take these medications. And if they have complications of use of this medication, nausea and vomiting, that they are written up for the medications for nausea and vomiting as well. They need to be told when they will be followed up, and if the complication occurs, what they need to do, who they need to contact. So all these are very, very important. So as we look at the era, so this situation was basically about early recovery after surgery. And if there is inadequate pain management in these patients, this can increase their stay in the recovery period. Like a patient wakes up with pain, they get opioids or other medications, they can become sick. That increases this length of stay, the recovery. And sometimes instead of the day case, they become inpatient because of this persistent nausea and vomiting or pain. So this will increase the length of stay in the hospital. And this leads to unanticipated hospital admission because patient came as day case, and now you need to arrange a bed for the patient to at least stay in the hospital. And again, obviously, the whole idea of the early recovery from after surgery is to get back patient to their daily living function. So this is delayed as well. And obviously, all this leads to decreased patient satisfaction because their expectation was that they will get home the same evening. They will be able to actually start doing the activities they normally do from day one. So you have not met their expectation. So pain management is very, very important part of the ambulatory surgery. So in brief, you need to look at the ERAS is about intraoperative multimodal analgesia. It is about pre-op preparation, information, and education. I call it PIE. Okay, you give them a piece of pie. Okay, you prepare them for what they are going through. You give them information. You educate them. Post-op management of pain and its side effects are important. The instructions for the post-op management of pain are equally important, and so is the follow-up. And there are socio-cultural issues associated with pain. Some patients may not be able to get back to the normal because they do not actually have support at home. So you need to also look at that. So we come to the second case. Second case is a 60-year-old man. He's got a history of smoking. And he also has COPD and is now scheduled for thoracotomy for removal of carcinoma in the right middle lobe. So this patient is going to have a thoracotomy. Why is this important? This is important because this is a surgery that is associated with persistent post-surgical pain. So incidence of the persistent post-surgical pain in thoracotomy is 5 to 6 to 7%. In mastectomy, 11 to 57%. Cholecystectomy, 3 to 56%. So there are actually various surgeries, even simple surgeries, like varicose vein surgery, cesarean section, hysterectomy. These are associated with persistent post-surgical pain between 12 to 27%. So management of persistent post-surgical pain is about preventing peripheral sensitization of primary hyperalgesia. We actually have seen that tissue injuries cause the release of arachidonic acid. There is prostaglandin synthesis. There is nociceptor activation. There is peripheral, sensitization and hyperalgesia, which causes pain. So if you actually manage the acute pain very well, then it won't, lead to the chronic pain. Because if the intense and there is intense and prolonged noxious transmission within the pain system, that will actually cause chronic pain. So this patient is having a thoracic surgery. So we have major goals. One thing is obviously the pulmonary function will be impaired because of the surgery itself and the lung reduction. And there will also be worsening effect of pain, splinting and atelectasis happening because of the splinting. And then again, oversedation from analgesics can also promote respiratory depression and atelectasis because that causes shallow breathing, which lead to atelectasis. So the early postoperative period, we need to actually optimize and balance the pain control, and we need to maintain the pulmonary function. So, deep breathing. So this patient is having a surgery in the chest, the thoracotomy, and you want patients to breathe, take deep breaths, and this itself leads to pain. So if you don't actually have enough pain relief or good pain relief, then patient won't be taking deep breaths, which will cause splinting and atelectasis, and because patient won't be breathing enough, won't be able to cough, this leads to respiratory complications. So preoperative planning is important. You need to actually tell them how you are going to assess the pain in these patients. what are the realistic expectation about intensity and duration of postoperative pain. We'll have discussions about whether, which is good for this patient. Can they have a thoracic epidural or PCA? And what are the resources available to us to prevent chronic pain? Because if the pain goes beyond their expectation duration, then this can lead to persistent post-surgical pain and chronic pain. So we need to discuss that. So we need to make patient aware what they are to expect after surgery. They need to understand what the procedure involved, what is their realistic expectation of pain or rehabilitation. And you need to also show that, yes, there can be severe acute postoperative pain, which can progress to persistent post-surgical pain, but we can take care of it. Okay. We have got the means of taking care of it. So the thoracic epidural is a mainstay of the recommended therapy, but sometimes the epidurals can fail or they can be patchy. In that case, we can actually give them intercostal nerve blocks, we can give them parietal block, we can give a rectospinal block. And again, these blocks can be used as a bridge for immediate post-operative pain relief. And also, we can actually use it, to bridge it till we actually reinsert the epidural. So epidurals can be replaced. If they're not working properly, they can be replaced. Or we can actually insert intercostal catheters or parietal catheters can be placed, or rectospinal block catheters can be actually also placed as alternative strategies for pain management. Then there are actually pain which are not associated directly with the surgery. For example, they can be shoulder tip pain. Okay. This happens from the diaphragmatic irritation, and this is carried through vagus and phrenic nerve, which are not going to be blocked by the epidurals. In that case, they can be managed by using non-steroidal COX inhibitors, giving them regular paracetamol. You could actually have topical lidocaine patch, gabapentinoid. So supplemental analgesia could be required for pain from other sites as well. So that is the other expectation that we do back. So this case was about prevention of persistent post-surgical pain. Again, it involves pre-op preparation, providing them information, educating the patient about the pain, and their expectation, how we're going to manage. Intraoperative, yes, we need to use multimodal analgesia, but we are going to take advantage of which anesthesia here. Okay, do we put an epidural catheter, or do we use a parietal block, rectospinal block, intercostal block? So, okay, this will be important part of the management. And post-op management, we need to make sure that the epidural is working fine. If it's not working, we have alternatives to it. Okay. And obviously, this is not a case which is going to discharge. The patient is going to be in the hospital for a few days. Sociocultural things actually don't become as much important till the patient is discharged from the hospital. In that case, how they're going to manage the pain in the post-operative period, their follow-up, their support, all becomes very, very important. The third case is also very important. This is a 70-year-old woman, and she's got a metastatic breast cancer, which has been treated for the last 6 months. She uses a transdermal fentanyl patch for a cancer pain, and she is on pretty high doses of fentanyl. So she's on 100 microgram per hour patch every 72 hours. Now she is fell and now actually has got a hip fracture. And patient was very dissatisfied with the post-operative pain management after a breast surgery 3 months ago. So this is a patient who is on a long-term opioid therapy, and so there is issues with the way her pain management was in the previous surgery. So what we have is a patient who's had a bad experience in the past, and this is a patient who's going to require much higher opioids. And this is a surgery which is associated with increased risk of persistent post-surgical pain. So we need to remember that aggressive treatment of post-operative pain is very important. And tolerance to one opiate preparation can lead to tolerance to other opiates as well. So it may be that you need to use other modalities of pain management for this case. So what does chronic exposure of opiates lead to? So there are two things. One thing is that it can lead to tolerance. In case of tolerance, what we're looking at that the same amount of pain require progressively increased doses to manage the pain. But there is another thing known as the opiate-associated hyperalgesia or opiate-induced hyperalgesia. Now, this is a neuropharmacological phenomenon. Okay. So paradoxically, in patients who developed OIH, increasing the dose of opiates only make things worse. And sometimes these two are coexisting in these patients. So you can actually have tolerance as well as hyperalgesia can coexist. That makes management of pain very difficult. Then there are patients who might actually deny abuse of the drug. So the patient has been told that they only require 100 micrograms of fentanyl per hour, but they may be actually be consuming more than what they have been prescribed. And these patients often actually have coexisting psychiatric problems like depression, anxiety, psychosis, personality disorders. And we know that depression and anxiety are independent predictors of severe post-operative pain. They are also associated with persistent post-surgical pain. These are risk factors for persistent post-surgical pain. So these patients are vulnerable to inadequate post-operative pain control. So what is the anesthesia technique we use? So this is the area where you actually have to individualize. There's no data favoring general or combined anesthesia. And if you look at individual consideration, then most people will actually go for a regional anesthesia technique that know that these patients may not behave as we expect, or they may require massive amounts of opiates to control pain. So the expert opinion actually tilts towards regional anesthesia or neuroaxial anesthesia wherever possible. So in this case, there are two goals. One thing is to provide effective analgesia, and second is prevent withdrawal. So in patients who have increased opioid requirement, where do we go? Do we go for G or go for regional? I've already explained that this is very important, that even if patients actually are having regional anesthesia technique, we still need to at least provide them the opiate support. And you can do this. The opiate requirement during surgery is a combination of the daily opiate dose the patient takes, plus the opiate dose that is required for that particular surgical intervention. So for example, if the patient is taking equivalent of, say, 30 milligrams of morphine daily, and you tend to actually use 10 to 20 milligrams of morphine intraoperatively for a hip procedure, that means that daily the requirement for this patient is going to be 50 milligrams of morphine. Now that's huge, isn't it? So people might be reluctant to use that kind of dosage. And the other thing is to actually use continuous infusion of opiates, and also use long-acting intravenous opiates for managing the pain. Even if you actually use the regional anesthesia techniques and some amount of multimodal analgesia intraoperatively, the dose requirements in post-operative periods, it might be difficult to catch up. Okay. The recovery staff may be reluctant to administer larger dose of opiates. You have already used, say, around 50 milligrams of morphine intraoperatively, and you are actually asking the nurses to actually give another 20 milligrams of morphine to the patient. Now, that the recovery nurses may not actually be happy to administer. They might actually want you to stay with the patient and actually administer that extra amount of opiates. So individual patient requirements, these are difficult to predict. And even in patients who are on modest dose of opiates, say less than 50 milligrams per day, of morphine equivalent before surgery. Requirements can be pretty high. So requirement will be 50 milligrams of the morphine plus 2 to 3 times the opiate that you would normally use in an opiate-naive patient. So say, for example, like I said, you use 20 milligrams for hip surgery. That means now you need to actually use almost 40 milligrams, right? So 2 times, 2 into 20 or 3 into 20. So 40 to 60 milligrams over that 50 milligrams. So you need to do 50 plus 90 milligrams of morphine. That's a huge amount. Like regional anesthesia technique, obviously wherever can be used should be used, and catheter techniques will be very useful because here you can actually also use neuroaxillary opiates can also be used, and this will mean that you can reduce your opioid requirements. Just because you're using regional and neuroaxillary technique does not mean that you cannot use systemic opiates in this case. Okay, these are important that the patient get their usual oral opiates, and you might need to use additional opiates intraoperatively to prevent opioid withdrawal in these cases. So opioid withdrawal management is another important part of this post-op management. This can be done by opiate rotation. They use a different kind of opiates from what their patients have been using. PCA, we normally use, say, 0.5 to 1 milligram boluses. You might actually use a larger bolus and shorter duration. So you might actually have to change that as well. And again, you can actually change, and you can also administer a basal rate on the PCA. So there's a constant amount of infusion of opiates. So withdrawal from opiates prevention is very, very important, and this needs to be decided in the preoperative period itself. What opiates are you going to substitute? Okay, and if you're going to use the same opiates, how are we going to use? Are you going to use another route? Okay, are you going to go from oral to IV, and when you do IV to infusion? So these are actually very important aspects. Now, one drug which actually comes in rescue here is ketamine. And we have discussed this, that ketamine reduces opiates requirements, both intraoperatively and postoperatively. And these can be used as an infusion and as an opiate-sparing drug. It also can be used as a bridge till patient is able to actually take their normal medication already. So perioperatively, it's a very good adjunct to use in these patients. So multimodal analgesia regimens is combination of non-steroidal, paracetamol, gabapentinoids, topical LA. Everything is very, very useful. It's important to understand that we do not use opiate antagonists like naloxone, naltrexone, or mixed agonists like buprenorphine or pentazocine, because these can precipitate acute withdrawal reaction in patients who are on opiates. So we have to be very, very careful. They can be difficult to manage these patients. When you discharge the patient, you need to actually look at what opiates you're going to prescribe. You need to make sure that these opiates you prescribe are not abused or misused. Okay. And you need to actually appropriately use the non-opioid analgesics as we have discussed. They need to be communication with the physicians who are looking after these patients. And we also need to have a program where we need to taper, because we have used much larger doses intraoperatively. How are we going to taper the amount of opiates used? This patient actually has transdermal fentanyl patch. This can be left in place, okay? And obviously, there is a lot of counseling which actually goes on about opiate prescription in the post-operative period. Patient might ask that I'm only on 100 microgram patch. Can this go further? Or when can I actually change it? So that also becomes part of the treatment. So the last part of the lecture is about opiate-free anesthesia, because there are problems with opiate as analgesics in the developing countries. There are questions about procuring, how do you procure them, about legalization, and the risk of addiction. Opiate-based anesthesia has always been the primary part. Using opiates is the important part of using, managing post-operative pain. So the trial, we know that the muscle amnesia, muscle relaxation, analgesia, this trial everybody knows. But if you take away the opiates from this and muscle relaxant, so we can actually have a lot more different methods of using, non-opiate agents for managing analgesia in the post-operative period. So the the solution to this consists of understanding the pain pathway, which we have discussed, using NMD antagonists like ketamine and magnesium regularly, using alpha-2 agonists as part of your management, using peripheral and neuroaxial blocks to supplement analgesia, and using other agents like regular paracetamol and non-steroidal as part of the multimodal analgesia. So we have already discussed about the pathway, how the nociception is transmitted through the spinal cord, midbrain, to the thalamus and the cortex and the limbic cortex, sensory and limbic cortex. So we can, at the peripheral part, we can use local anesthetics, we can use paracetamol, anti-inflammatory COX-2 inhibitors, we can give nerve blocks, we can use local anesthetic as part of the blocks, as well as infusion, you can opiates, alpha-2 agonists, and NMD receptor antagonists. Centrally, opiates are used, but we don't actually have to. Alpha-2 agonists, paracetamol, like I've explained, has got central as well as peripheral effects as well. And NMD receptor antagonists like ketamine and magnesium, fantastic drugs to be used, which have again got peripheral and central effects. So the common drugs, now take away the opiates from all this, you can actually still provide good amount of analgesia. So if you have a surgery that has got both somatic and visual components, that's what you can use. So if it's just somatic, regional anesthesia actually works very well. In that case, multimodal analgesia should consist of dexamethasone, diclofenac, magnesium sulfate, paracetamol. If you want, you can add ketamine to this. You can use dexmedetomidine to it as well. But from our experience, we've seen that these are more than enough. But if there is visual component as well, so regional anesthesia can be abdominal blocks, parietal block, erector spinal block, peripheral blocks. Okay, you can actually use any of these blocks. And multimodal analgesia would be a little bit more extensive than if it is purely somatic pain. So dexamethasone, anti-inflammatory, diclofenac, non-steroidal, magnesium sulfate, and lignocaine infusion, clonidine or dexmedetomidine, small doses, paracetamol, and small dose of ketamine, which are not included, again, can also be used. These are some examples which have used, again, mild pain is easier to treat than moderate and severe pain. But combining regional anesthesia technique with simple multimodal analgesia, you can take away opioid. The opioid requirements can be markedly reduced by using regional anesthesia technique and multimodal analgesia. This is just telling in the tabular form what we can use, like peripheral blocks, intraarticular blocks, infiltration of incisions. All these have greater advantages in management of pain. Non-opioid systemic analgesics, paracetamol, non-steroidals, oral, or even rectal, non-steroidals, gabapentinoids, all are very, very useful. I have also described mixtures like the first mix was tramadol with paracetamol, using low-dose tramadol mixed with IV paracetamol, given 15-20 milligrams before the end of surgery. Actually works fantastic. Then I described use of another mix, which is basically 1 gram of paracetamol, in which you use 100 milligrams of lignocaine, 1.5 milligrams per kg, and 2 grams of magnesium sulfate. This was given 20 minutes before intubations, mainly was meant for that. But it can also be used in simple surgeries. Or You can use combination of two. So what you do is a mix two. You also actually add tramadol and use it as an infusion. So this is a simple mix. The newer development, like I said, this is a paper which actually came out just this month, and they're talking about fixed dose multimodal combinations. And that says this is dose convenience, because patients are easy to take one tablet than take multiple tablets, and they have greater analgesic efficacy and fewer side effects because you're using multiple doses, drugs in smaller doses. And obviously, there is opioid sparing effect as well as ease of administration. And these are some of the combinations, some which I have already described along with paracetamol, tramadol, paracetamol, choline, oxycodone. But there are also combinations where non-steroidals have been used with opiate, simple opiates, tramadol with diclofenac or dexketoprofen with tramadol or ibuprofen with codeine. These are other simple premix which are available for management of post-operative analgesia. So given regularly for the 48 to 72 hours, can markedly reduce the requirement for opiates. And these are the common drugs which with doses, I will post them on the group. And this just tells you what doses you can use intraoperatively. Post-op doses are to be titrated. They're never given as a big bolus. They're always titrated in a small doses. Then we have the other periop analgesic drugs which are non-opioid based. So we have rectal non-steroidals like ibuprofen, diclofenac, naproxen, oral NSAIDs like ibuprofen, diclofenac, IV NSAIDs, diclofenac, ketorolac, and ibuprofen is available in the US as well. Paracetamol can be given rectally, orally, and IV, and the doses again are slightly different for IV. So you need to be careful with patients who are less than 10 kgs. More than 10 kg, the doses are totally different. Lignocaine, like I said, is a very important drug. At induction, you give 1 milligram per kg bolus. Intraoperatively, you can use 40 microgram per kg per minute infusion. During surgery, then you reduce it to 0.5 to 1 milligram per minute towards the end of surgery, and then continue it in the full recovery and post-op day 1. The dose is the same. It is continued from 0.5 to 1 milligram per minute, and you stop it on the second post-operative day. We have seen that the effect of this drug actually continues. But it's also important that when you're using lignocaine infusion that you monitor for the toxic effects. And you should actually have the intralipid in case patients develop the last. Magnesium sulfate, this is available as 0.5 gram per ml, usually 2 ml ampoules are. So each 2 mLs contain 1 gram of 4 millimoles, and the dose is 50 milligram per kg. So in 70 kg man average, you use 3.5 grams or 3 to 4 ampoules, which are equivalent to over 16 millimoles, are slowly infused. You need to be careful because rapid infusion can cause hypotension. Large doses, again, can cause hypertension, sedation, and they can also prolong the neuromuscular blockage. So if you're using it larger doses, do monitor the neuromuscular blockage. This is what I normally use in my cases. I have more than 10,000 cases where I have not used single opiate, not even fentanyl. No fentanyl, no morphine, using blocks. So ibuprofen for blocks, peripheral or central blocks. And then I use diclofenac, lidocaine, magnesium sulfate, ketamine. So some ketorolac, that is the clonidine, and dexamethasone. Every patient gets dexamethasone. That's the important drug. This is how most of my anesthesia looks like. Very stable anesthetics, and I tend to use MAC of 0.7 to 0.88 in most patients, because like I said, most of the drugs actually have central effect as well. So they have anesthesia sparing effect. So not only opiate sparing effect, but also anesthesia sparing effect. This is a simple, I think, small short surgery where we used dexamethasone paracetamol. They would have also got a bit of magnesium sulfate as well in these cases with IV paracetamol. This is a case where the patient actually has got severe aortic stenosis, and this is a patient has got CKD as well. You can like the eGFR is only 26. Coming for hip surgery. So we have used femoral nerve block because this patient, I think, had some other disorder as well. The patient was on anticoagulants. And this is the anesthetic chart. You can actually see that we have used dexamethasone. We used ketamine in this. So the induction was with propofol and ketamine. Patient had hemiarthroplasty, and we were using ketamine as an infusion as well. So it's a very important adjuvant to management of analgesia. So in summary, acute pain needs to be managed aggressively. We require preparation. Preparation starts in the preoperative period, and the patient you need to align with their patient expectations. Multimodal anesthesia is the key to maximize desirable effects and minimize side effects. MMA can be provided even if there is no access to opioids. And use of regional anesthesia technique is key to providing multimodal analgesia when opioids are not accessible. And fixed dose multimodal combinations will help further in managing post-op pain effectively. And these are some of the newer changes which are coming in for post-operative management. Thank you very much for listening to this lecture, and see you later.
Hi, Rohit. Hello. Hi, Dr. Gurmeet.
Hello.
Yep. I think it was a pretty
Hello.
long lecture. Yeah.
Hello, can you hear me?
Yes, we can. We can hear you.
Yes, it has been a very exhaustive and
Yeah.
very informative
Yes.
lecture from your side, sir. So
I
I
could
hope that all the panelists have really liked it.
Yeah,
And
it would have gone for longer, but I mean, there's so much we can actually talk about each component of the acute pain management, and I think it's
definitely this is a very exhaustive topic, which cannot be covered in one lecture.
Yeah, I'll try to actually include, I think, most of it, and because I said I will actually talk about what is the evidence base as well, so that has extended a bit because there are lots and lots of studies as well, but then you have to restrict it to the most important ones. So I try to actually include that, and there's so many agents which we use for acute pain, so we need to actually again try to actually also talk about them. We can't just leave one group of drugs and not talk about others. I think Rohit is,
and then there are so many regional techniques which can be tackled.
Yeah, they are that regional anesthesia technique, or I think on its own, there are different lectures what we use for each of them. So I actually have a kind of an anesthesia plan for most techniques, which I can actually share, like what you do if you're in the best setup. You got everything, what you can do. What can you do in an intermediate setup, and what you can do in a setup which actually does not have very many things. You don't have ultrasound, you don't have PNS, you don't have opioids, even that setup. So we can actually discuss those in that way as well. And maybe we can cover few of these if we actually have a list of topics in that way. It can be discussed as well. Like I said, this we can go on and on for a long time discussing each of them.
Oh yes, definitely.
Yeah.
we like to discuss more often with the when we don't have much of the gadgets like ultrasound, opioids. In Jammu, most of the places in our setup, we don't have these facilities available, opioids and ultrasound and others.
Dr. Gurmeet, I think that is not an issue at all. I think what is important is to actually have a basic understanding. If you know the basis, you have a foundation, then you can actually give as good anesthesia as you would give in an institute in Harvard or in Liverpool or in London. Okay, without actually requiring too many things, you can actually provide very, very decent anesthesia, analgesia for most patients.
That is what most of the anesthetists from our Jammu region are giving. We're taking all using general anesthesia techniques or regional blocks.
Yeah.
Might be just without this ultrasound, but we are all doing all this.
Yeah. So my I think take on this, what I have been actually trying to say is that people don't realize. I mean, if you have noticed that one of the slides I was talking about the persistent post-surgical pain. Now, patients actually tend to suffer from them because we do not follow up these patients. So you can actually give a very good anesthesia just by using epidural or spinal. So unless you use multimodal along with it, you're not going to give proper anesthesia. It is not. You have to use multimodal analgesia even with giving spinal. Even cesarean section, the incidence of persistent post-surgical pain is as much as 25 to 27%.
Sir, it has to be a tailor-made anesthesia.
Yeah.
It has to be a tailor-made anesthesia as per the need of the patient. Not on a very fixed. We can go with a fixed idea to what to give.
Yes.
It all depends upon the requirement of the patient.
Yeah. No, but
need of the patient, type of the patient.
Yeah. So simple things like
so sorry, I need to interrupt.
Yeah, sorry.
Shiv, I need to interrupt here. We have a question answer session.
Yeah.
So one question, if you might have read it, one question is here by Dr. Sumera Ghosh.
Yeah.
She says, what is the role of the buprenorphine patch, 10 milligram, and what is your opinion regarding this?
Yeah, so the patches, we talked about fentanyl patch and similarly buprenorphine patches. Now, these are not actually meant for acute pain management, but you can actually get patients who actually come with these patches on, and you need to leave them on. Okay, so like you discussed in the third case, I deliberately actually use that third case as an example because it is important to understand that even patients who are on chronic opioids, they actually require much higher doses intraoperatively. And even if you give regional anesthesia, they may not actually solve the problem. So these patches are not part of the acute pain management. Even though in India they're using it, I know it very well that they've been used as the part of acute pain management. People need to realize that there are better drugs which can be used for post-op anesthesia, analgesia. So if they're already on them, no problem at all. Leave it on. Not actually tamper with that. Using them as a part of acute, every patient is different. First of all, the patches actually takes 24 to 48 hours to actually peak. So you're leaving the patient without any analgesia for the initial period of time. So unless you actually take care of, because the pain is actually maximum in the 24 to 48 hours. If you're not taking care of that, then you're not actually doing it. Now you could actually say, can we actually start the patch at the beginning of the surgery? Even then, you're not going to get that 12 to 24 hours period of, you're not going to have the fentanyl or buprenorphine actually is stored as a depot in the fat, and then it is absorbed into the circulation. So the peak actually occurs very, very slowly, and that's why it is used for chronic pain.
Right. So Sumedha also wants to know what is the role of the decadron when you are using it with the opioids in preventing the pruritus or vomiting.
Yeah, so no, that is dexamethasone. That's why I think they meant.
Exactly.
Yeah, so that's why I actually I went through the physiology of pain. Right, people do not understand that there is a lot of things happening. If you look at the neurotransmitters which are released in acute pain, there's no difference from chronic pain. Okay, there's a lot of inflammation. You need to actually use anti-inflammatory. So one thing, dexamethasone is anti-inflammatory. 2, it reduces post-op nausea and vomiting. 3 thing is that if you're using nerve block techniques, you don't have to mix it. You give it IV and it does the job. Right. So it will prolong your analgesia. So the analgesia of a single block can be prolonged from 16 to 18 hours without any problem, just by giving IV. Okay. And you're getting the other effects of the dexamethasone. So dexamethasone need to be used. There are very few contraindications to using dexamethasone. And it is long acting also. So that's the thing. That's one of the advantages with single dose, is that its effect lasts for almost 24 to 38 hours, 36 hours, yeah.
Right. Dr. Anita is our consultant. She's the associate professor in Medical College Jammu. She wants to know what is the protocol for giving the gabapentin.
Sorry, protocol for?
Yes, protocol for giving the gabapentin. She has a question called, sir, how do gabapentin help in intraoperative pain?
Yeah.
When given for the pre-operative session, and what is the protocol? So you have answered the first session that we have seen. The other one is, what is the protocol?
Yeah, so there is actually, we do not have any protocols as such. Now, if you look at the recent evidences for the use of gabapentinoids, it is said that actually they are not meant as for acute pain management. But saying that, they can be part of your multimodal analgesia. So we are using it as part of the multimodal analgesia to prevent chronic pain, especially in the hip and knees especially. So we actually start them with 75 milligrams. We use pregabalin. We don't use gabapentin. We use pregabalin. So we use 75 milligrams of pregabalin in these patients, and we tend to start them the day before surgery. Okay, so they will get at least one dose the day before, and the second dose will be given in the morning of the surgery. So they'll at least get 75 milligrams of this pregabalin. You don't have to use very big doses. Yeah.
Very big doses. Fine.
Yeah.
Fine. Dr. Shiv, one more. This is an anonymous attender.
Yeah.
She has given a question. Can we give an infiltration underwent the septic laparotomy? Infiltration of the local anesthesia.
Yeah, absolutely. You can actually use infiltration for abdominal wall. You're not actually got a local infection. It's not like giving a local anesthesia where there is infection, where there is acidity, which will not work. But if you're actually going into the abdomen, your surgery is actually away from the infection. Infection is visceral. It is inside the abdomen. It's not affecting the incision site. So you can use infiltration for local anesthetic. It's not a problem. So, but if you actually remember one of the slides I mentioned about when is infiltration better? Do you give it before or give it after? So if you actually have to get a better effect, then you do it before the incision goes. So you know that the incision is going to be, say, 4 centimeters, 8 centimeters. You infiltrate that before you actually put your knife on. Then it's going to go work better. And the same thing is true for nerve blocks as well. If you give nerve block after the surgery is over, then the effect does not last for more than 4 to 6 hours. But if you give the nerve block at the beginning of the surgery, then the analgesic effect can last for anywhere from 16 to 24 hours.
Right. Another question is here.
Yeah.
This is from Dr. Sunny. He says the lignocaine is an anti-inflammatory. What is your view it can be used in COVID-19 to prevent the inflammatory response and cytokine response.
yeah, yeah. There is one guy who's actually using local and I don't know what Hamadi or something like that. Guy, I don't know from where. I think from Iraq. This is from Iraq. Yeah, this guy is saying that
he's in fact giving the lignocane in the inhalational form also.
Yes, nebulization. He's using it as
nebulization. Yes.
Yeah. In the end, it is basically like, because if you use nebulizer, it is going to be absorbed. You are actually delivering local anesthetic at a large area, surface area, it will get absorbed. So the absorption will occur. So it's the effect is systemic. Okay, it's not a local effect, anti-inflammatory effect. It obviously acts at the site where the inflammation is happening. That is where it is going to act. But it get absorbed. Basically, what is happening is that it is getting absorbed into the circulation, and then it works. Does it work for COVID? I don't know, because that's not the experience. And COVID is a very complex disease. It's not just about inflammation. So just actually trying to say, maybe you can use it as one of the treatment modalities, but this is not going to prevent the progression of the disease.
Sunny has one more question for you, Shiv. He's saying that looking at the new formulation change in propofol medium chain triglycerides as compared to the commonly used propofol LCT, what is the clinical experience about it?
No, the change in the formulation for is the long chain triglycerides, actually using them is mainly for preventing pain on injection. The pain of injection is much less than the older preparation, no doubt about it. Okay, so this is just to actually make sure that but the best thing what works for these is actually giving propofol in a running drip, in a large you need to have large size cannula, and you need to give it a running drip. So we are still see patients who will, that numbers is reduced markedly. We still see patients who actually do get pain on injection of propofol with newer formulations. As far as dose doesn't change. It doesn't change the way it has been given. The dose remains the same.
Okay. Sure, Dr. Lofi has a question for you. She says the intrathecal opioids, as you said, cause no respiratory depression. But is there any evidence or statistics of the same for the respiratory depression?
No. Actually, it depends. Obviously, the intrathecal what opioids you're going to use, that is very, very important. So if you look at fentanyl or diamorphine, these are highly lipid soluble, so they get fixed very quickly. Morphine, they say they can be, because it's not as lipid soluble as fentanyl or diamorphine. Then say, can there be a effect because it can move grossly? But with intrathecal, it's not been seen. So if you look at the studies I actually posted, there was not a single case of respiratory depression with use of intrathecal morphine in these cases. So there is no, with epidurals, large doses, they say they can have a second response. That is because, some of the drugs which is given epidurally is going to be absorbed systemically. So that respiratory depression is actually more from the systemic absorption rather than from the central effect of the opioids.
Okay.
Fentanyl, morphine, they are safe, absolutely safe.
Okay. Sunny, we have Dr. Dhruv with us. Dr. Dhruv, can you hear us?
Yeah, Dhruv, I know him very well.
Dhruv, are you there? Dhruv, can you hear me? I think Dhruv has moved. Hello. Dhruv, can you hear me again?
I think a lot of people probably got bored of the long lecture. I just moved it. Yeah.
Yes. So many people are here, and we have one. Hello, can you hear me, Dhruv? Okay, one of your fans, very good fan, is here, Dr. Jyoti Sakral. Jyoti Sakral, can you hear me?
Rohit, Rohit,
Yes.
I think the attendees cannot actually participate.
Yes. I think probably.
Yeah.
But
They
I have
can-
a lot of many questions are here.
Yeah.
But probably I'll be forwarding them. I'll be forwarding them to you.
Okay.
So if you could answer them and send me, so that I could send them back to them.
Yeah, of course. Or they can post it on the group as well. If they want a interaction, they can have under this the post, because I posted actually quite a few of these on the group, so they can always have a very interactive session, question answer
So
session.
Shiv, it was really a very interactive session, and we are really thankful to you for sparing your time for us,
You're most
and
welcome.
particularly for Indian Society of Anesthesia Jammu chapter. It
Yeah,
has been a wonderful experience to interact with you.
I
And
love
we
it.
are looking forward. We'll be looking forward to hear from you on many different other topics.
Oh, you're most welcome. Most welcome. Absolutely wonderful. And thank you,
Good
Dr.
night,
Gurmeet. And it's a pleasure.
Thanks a lot, sir.
Absolutely.
Thanks a lot, sir, from all of us.
Shiv, again, I just want to thank. I want to thank Mr. Jagrup Singh, who is the Vice President of the Acula for Intas Division.
Yes.
Mr. Ajay Kotha, the Marketing Head of the Acula Division. They have managed it very wonderfully.
Absolutely.
So
Absolutely.
we are looking forward with Acula to have many more other interactions.
Thank you.
Thank you, sir. Thank you very much.
So thank you all.
Thank you, Amit. Thank you.
Thank you all.
Bye.
Thank you.
Bye. Good night.
Good night. Good night.
Good night, sir.
Okay, thank you, Dr. Shiv.
Okay.
Thank you, Dr. Gurmeet.
Bye-bye.